Will be called back to order. Welcome back. Before we return to the testimony on the Medicaid health plan services, we are going to bring up House Bill 4328, which is sponsored by Representative Fairbairn, which is a supplemental appropriation for the natural disaster relief for the affected communities in northern Michigan that we've experienced over the last couple of weeks. It is time sensitive, and joining us will be Representative Fairbairn, Cavett, Roth, and Borton. But first we're going to call up Robin Risku from House Fiscal and give us a detailed overview of the bill, of which you are getting copies in the fiscal analysis at your place. Thank you, Robin.
Thank you, Madam Chair and members of the committee. As the chair mentioned, House Bill 4328 before you. It's a supplemental appropriations bill containing $75 million general fund for the Department of State Police to administer a storm disaster relief program. Under the bill, the department would be required to allocate funding to local units to assist with identifying and securing disaster assistance for individual residents, businesses, and communities that have realized a significant financial hardship caused by recent storm damage. Language in the bill specifies purposes for which the funding can be used. Those purposes include, but are not limited to, state match funding required for receipt and expenditure of any federal funding that is made available for emergency management assistance, emergency actions needed to protect life, property, public health, public safety, including shelter and emergency supplies, labor assistance, including unemployment benefits, temporary employment opportunities for disaster recovery, and assistance with cleanup and recovery, and support for dislocated workers, energy assistance, including paying heating and electricity bills, preventing shutoffs, and providing crisis assistance, and repair or replacement of disaster-damaged infrastructure, facilities, and private nonprofit organizations. Language in the bill also requires any of the remaining funds to be allocated on a first-come, first-served basis for addressing damage on land owned by the state and by the Department of Natural Resources, and to reimburse other third-party providers that assisted in disaster recovery efforts, to include reimbursing for costs of deploying emergency first responders. Lastly, the language designates unexpended funding as a work project account, authorizing funding that is not spent in fiscal year 2025 to be carried forward until it is all expended, or until September 30 of 2027, whichever comes first.
Thank you very much, Robin. And so when we have an emergency like this, is this typical process we appropriate to the Michigan State Police for emergency?
Correct.
Thank you. All right, thank you very much. With that, Representative Fairbairn, if you would like to come up and provide us with an overview of the bill, and also Reps Cavett, Roth, and Borton.
Well,
thank you.
Thank you, Madam Chair and members of this committee. House Bill 4327 will appropriate approximately $75 million of state general fund to work in tandem with any future federal disaster declaration for northern Michigan. Federal disaster relief dollars would require a 25% match from the state, resulting in a $300 million total recovery plan for northern Michigan. Our northern Michigan communities are doing everything they can to address historic damage, but local funds are really running very short and they need the help. This was a once-in-a-generation storm, and we very much appreciated having National Guard, DNR, and other boots on the ground to help us get through the immediate aftermath of the storm. But northern Michigan is a long way from anything approaching back to normal. The damage and disruption we experienced is similar to that of a Florida hurricane, Category 5, a lot of linemen said. The Michigan State Police have initially estimated that recovery efforts will cost upwards of $200 million, but that number is likely to rise considerably once more thorough evaluations of local damage and devastation is complete. The funding provided by this supplemental would support disaster relief grants, which will aid local communities with emergency management assistance, continued operation of warming centers, and purchase of emergency supplies, cleanup and recovery efforts, unemployment benefits, and repair replacements of damaged public facilities. Madam Chair, rather than my going on about the devastation throughout all of northern Michigan, with your permission, I'd like to allow my colleagues in the Northern Caucus to have the opportunity to share their experience and observations as to allow the committee to ask specific questions of all of us. Thank you.
Thank you, Representative. And yes, Representative Cavett, would you like to start?
Yeah, thank you, Madam Chair. I appreciate you allowing us to tell our story today and get this out. It's not a widely covered story, which is unfortunate, but let's just say this, it's not over yet, Madam Chair. We still have 4,000 people in my district in schools that are closed, 4,000 people without power as we sit at this meeting right now, going on 18 days without power. A lot of people aren't aware of that, so I certainly thank you for allowing us to share our testimony today. But the storm came on a Friday and stayed with us through Sunday. Gale force winds came through northern Michigan. Basically, we all have our map. It's from the top of our finger, basically 72 across. Storm came, high winds, 2 inches of ice I recorded on my bird feeder outside of my house. I personally was without power for 8 days. It came on that Monday. I had office hours in Atlanta, Michigan, in Mount Morency County. Drove down 33 and witnessed firsthand some of the devastation that I saw. We had certainly lived through it. The trees popping, there's a noise that the trees would pop and then topple from the ice. It's something I'm sure none of us will ever forget, that noise. On the way there, conversations that we've had, I had a sheriff. We had nursing homes without power. We had hospitals without oxygen because nobody could get into our district. We had 911 calls that were not responded to because they were in areas that trees and power lines had crossed the roads. To put it in perspective, Alpena normally averages between 11 and 15 calls on a busy day. They're averaging 58 calls a day. So just the volume had increased greatly. Some of the telephone or poles that replaced, they usually do about 100 a year, where they did 2,800 poles this last 18 days. So, and it wasn't just a pole and line issue, it was a substation issue. So they're literally re-engineering our power grid on the fly, trying to get people back up the power. Numerous power providers were there. I know other folks are gonna talk to wanna tell their story also, so I don't know how long you want us to take, Chair. But, when I was in Atlanta, there was no fuel. That was the problem. There's not a good Michigander who can't do a 3 or 4 or 5 day storm on his head. Most of us have generators and things, but we ran out of fuel and there was no gas stations open because there's no power. And one of them, when some of them did try it open, there'd be a fuel rush. And I posted a video of social media at Freddy's in Atlanta, well over 100 cars in line trying to get fuel for those generators. So it was a life and death situation there, especially with the oxygen. I had sheriffs that call me that were just manic because the trucks couldn't get up here to supply these oxygen. So anybody on a medical device, they were just out of luck. It's just tragic, and I could go on, Chair, and I'll let some of my other colleagues tell their stories too, so.
Thank you very much. A very, very difficult situation, and appreciate that. At this time, too, I will be asking, but I would like to invite Representative Preston, if you'd like to come up, and Senator DeMoose. Many of us were on a call that Senator DeMoose had yesterday, orchestrated on the extent of the emergency. That, Rep. Borden?
Yes, thank you, Chair Bolin. Rep. Cavett covered a lot of it. My situation is very similar. 3 years ago in Gaylord, we had a tornado that came through there that was pretty devastating, but I'll tell you, that pales by comparison to what we're dealing with right now. The pictures, the videos, it just does not show the amount of devastation that's up there. We still have thousands of people that don't have power. We have people that can't get back into their homes. And probably one of the biggest issue now that the storm is done is going to be the cleanup, the aftermath, because there is so much material that has fallen that was laying in the roads. It's been pushed in the road right away, but something's got to be done with it. We're under a burn ban up there, thank goodness. I mean, a lot of people would love to burn that, to get rid of some of it. But we have to be under that burn ban, not only because it's dry, but the woods are filled with this fuel. A lot of the trees we lost were red pines. They're very sappy. They burn hot and fast, and it has to be dealt with. We need to find a place to move this stuff. We've got all hands are on deck. Our road commissions are ready to help, but we're at the point now where we need funding. We've exhausted our volunteers, and there's just nothing left. And it's at a point now where it's a very dangerous situation. It's a tinderbox, and we need to address it and work on it very soon. And one thing, from talking with some of the linemen, I asked them, I said, you guys do this all over the country, how does this compare? He says, we've been to Cat 5 hurricanes that weren't this bad. He said this widespread damage was just unprecedented. We have thousands of acres that had beautiful trees that now literally are just sticks. So we appreciate any help you can give us.
Thank you. Representative Roth.
Thank you, Madam Chair, and my colleagues have said it very well. I was actually lucky. The 104th District was right on the edge. We missed most of the damage, but we're still dealing with the damage. Our 911 center took over a lot of the calls that came in from northern Michigan that couldn't be reached. The staging areas for a lot of the electrical trucks were in Traverse City. Hotel rooms were not available in many parts of the northern Michigan area, so they needed to stay in Traverse City. So today, you still will go by the state park and see shift after shift of trucks that go back up at nighttime and take over for those that are working in the daytime. What's noticeable for me was I checked out my district after the storm, and to drive the edges of it was not so bad. You take 2 miles and go to the east, and it's a whole war zone. Little town of Elmira that most people probably never heard of. It's just east of 131. You drive down that, it's gone. I mean, the lines are on the ground still. Junction boxes, poles snapped in half. And now they're using farmers' fields to collect the debris and store it there until maybe sometime we can do something with it. For me, it was noticeable to be so lucky but not be just 2 miles away from major damage is quite eye-opening, I tell you, until you've seen it. Ken is right, and all my colleagues. There's millions of acres of forest that are now gone. They're sticks. They are gone. There will be no maple syrup gained from that area. The trees themselves are worthless unless you can harvest them and get them into lumber right away, and it's years to come. And I can tell you, we had a snowstorm in Traverse City area about 5-6 years ago. About 21 inches of heavy wet snow came in and took our power out my home was only out for 4 days. Luckily, I had a fireplace, and the kids thought it was fun to cook on the fireplace, and it was really fun for 2 days. The third and fourth day, it became less and less fun, and the house became cooler and cooler, all of us sleeping in the living room. By the fourth day, our upper level of the house was 45 degrees. So I can't imagine what these guys have dealt with, Cam and John and Parker, weeks without power and in cold weather. That's the other thing. We have not been given a break. We have 60-degree weather. We've been having 40-degree weather and snowed on Monday. So this is a major disaster, and I'm glad we're taking a look at this. Thank you.
Representative Preston.
Thank you, Madam Chair. My area of the district, we got hit with the ice storm. The snow started up in Delta County and moved northwest from there, but south and east of there was ice. We were out for 2 days. This has been, for us in Menominee County and much of the area that I live in, we've had about 5 of these over the last 10 years. So a lot of our biomass has, what you would say, been cleansed by previous ice storms and heavy storms, high wind events. But what has happened below the bridge, especially in Presque Isle and some of Great Lakes territories, is beyond catastrophic. I've never heard of a distribution co-op being 100% down. The gravity of that cannot be understated. The cost to build a substation alone can range from $200,000 to $10 million. Your cost per foot, just on a single-phase line, is $3. Insulators, $150 a piece. Your cross arms and your poles, you're talking about $2,000 for just a cross arm and pole. A lot of these cooperatives, they simply do not have the funds to rebuild an entire system. And what they are putting together right now is temporary. It's not their permanent build-out because they're trying to get the power up to everybody. So I would just encourage everyone to be as aggressive as possible, because what they are going through up there has never been seen by me. We've had, for our cooperative, 10,000 members, we've had a couple of $3 million storms. The cost on this one, I'm hearing estimates of 6,000 poles total, and that doesn't even include all of the other infrastructure between the substations, the transformers, the insulators, the cross arms, and then all of the mutual aid that has come pouring in. Our own cooperative has 2 crews over there. During the storm, we worked on getting crews out of Canada to help Cloverland, because Cloverland and the UP was down, and all of the cooperatives below the bridge, you couldn't cross the bridge, were being tied up, and Cloverland was literally on their own. So they were able to get restored. Like I said, I would just encourage you all to be as aggressive as possible on sending money their way, because they're going to need it.
Thank you. And Senator DeMoose, thank you for being here. Many of us were on your call and, the devastation and the expanse of it. And I know our schedules are off, so thank you very much for being here.
No, I appreciate that. And I can't comment to the specifics of this bill because we just learned about it 20 minutes ago. And I'm not sure about the dollar amount, the 75 million, because that's one of the things we're working really hard on, is to find out the exact dollars that are required. However, I will say it's going to be a big number. And I just want to put this in perspective a little. This is unlike any type of storm we've ever seen in northern Michigan. And we're pretty hardy people up there. But the sheer devastation is amazing in its scale, but also in the way it looks. And I understand people downstate haven't seen the coverage. We've been living this day in and day out for the past 2.5 weeks. And I think the reason, having worked in the television business, is because the images aren't dramatic, like a tornado, where you see houses that have just been obliterated. And fortunately, we're thankful for that. A lot of this damage is a little bit more subtle. I mean, people don't look at power lines every single day. They don't see the sheer number of trees is unbelievable. At my own house, we were out of power for 13 days. And I stood out on my porch, and I started laughing, saying, where do I even start? And I'll tell you what, in my own case, a few years ago, I'm worried very much about our homeowners and how do they even address this? Because in my own case, we had 3 trees taken down a few years ago and it was $2,500. I probably have 30 that are leaning. I don't have the money to take this down. I have a local police officer in Harbor Springs, very middle-class guy. These are not wealthy people, despite what people think when they hear Harbor Springs. The people who live there are normal people. And his insurance agent came out and said, yes, we'll cover the tree that's on your roof, but we're going to cut your coverage unless you cut these 3 trees down. And for whatever reason, he went out and got a bid for $18,000. Nobody can afford this stuff. So what's going to happen is we've got a problem on our hands long term, because you can't leave those trees from both a safety standpoint and from the standpoint of a wildfire, of which we've had several up in that part of the woods. With the sheer amount of fuel on the ground right now, this is going to be a problem. We worked closely day and night with our power co-ops especially, and they were telling me, as was already said, I talked to linemen who've served on huge hurricanes. They've all said, we've never seen anything like this. I talked to the head of Great Lakes Energy, and he says in a typical year, this was 3 days in a typical year, they might replace 800 poles. They had already in those first 3 days replaced 800 poles. This was you got to remember, this unfolded over day after day after day. And if you've never seen an ice storm like this, it's really remarkable what happens. I didn't expect it. The branch doesn't just nicely fall. You hear what sounds like a shotgun, And then there's a brief swoosh as you wait to hear, oh my gosh, is this going to hit something? And so it's been really, really dangerous. I'm thankful that you're all taking a look at this. Thank you for being on the call yesterday. We really are going to need help on this. And what, I'll just leave with this, that one of the sad realities of this storm, unlike a lot of other storms like hurricanes and tornadoes, where a lot of the damage is stuff that's insurable, a lot of this damage is not covered by insurance. And so the local units of government, individual homeowners, all these people are going to have to be taking up the mantle of fixing this and of replacing it. It's going to take months and months and months. So thank you for at least considering this.
Thank you, Senator DeMoose, and thank you very much. You all give a very compelling vision of what it must be, and it will be long-lasting, and the intent is that this will qualify as a FEMA emergency, and the state will get the 75% match from the federal government. And certainly, timing is an issue. We understand, too, that it is not going to be done overnight. It's going to be somewhat long, and thus, that's why putting it into a work project. So thank you for that. With that, Representative Farhat. You can ask a question. I see that you have an amendment.
No, I just first want to commend you all for the work, Senator DeMoose. I was also invited to attend that call. And I just want to say I look forward to the opportunity to come up there and seeing the damage firsthand with you folks and just helping out however we can. So I just wanted to say that there. And again, it's a serious thing that's going on.
Thank you. Representative Steele?
It's not necessarily for the presenters, but just overall to the bill. Is this the time to ask the question?
If it's a technical question, yes. If not, no.
The technical question would be, how are they able to administer it to make sure it lands in the right spot to the right people at the right time? Who actually basically pays the bills or verifies that these are the correct bills to pay?
So the emergency, every county has emergency operations plan, and when any money comes down from the federal government, and in this case would come from the state, there are a lot of restrictions and requirements for reporting and submission, and even the calculation of the damage, which is, right now, the damage just continues day after day, as I understand it, and to quantify that in a dollar amount is ongoing. But we need to initiate the process. All right, with that, Representative Farhat, you'd like to offer your amendment?
I can do that right now. So, thank you, Chair, and thank you, gentlemen, for this. Really, again, it's really important. My understanding is that there's a huge disaster going on and that we want to be proactive, and the need for the FEMA money is really important. In noting that in line of my amendment here, we would just highbar this to Senate Bill 55, which has about $50 million that is waiting right now to be dispersed for communities that have requested it from FEMA. I think communities are all hurting, and this would be a good way to make sure that everybody who's counting on emergency relief can get it in a timely and fast fashion. I hope this is a common sense amendment that my colleagues join me in supporting.
Are you moving your amendment, Representative?
Yes.
Representative Farhat moves his amendment. Would the clerk please take the roll? The vote.
On the motion to amend House Bill 4328, Chair Boland.
No.
Representatives Maddock. Green. Jenkins Arno. Kelly. Markkinen. Mueller. Slaw. Van Workum. Beeson. Horton. Roth. Cavett. DeSena. Kuhn. Steele. Robinson. Farhat.
Yes.
O'Neill. Rogers.
Yes.
Steckloff. Glanville.
Yes.
Edwards. Yes. Martis.
Yes.
McKinney.
Yes.
Morgan.
Yes.
Price. Yes. Snyder.
Yes.
Longton.
Yes.
Madam Chair, you have 10 yeas, 16 nays, 1 pass. The amendment is not adopted.
Okay, thank you. And sticking within the current fiscal year, Representative Cavett moves to report House Bill 4328. And gentlemen, if you'd like to come back to your seats, and thank you.
On the motion to report House Bill 4328, Chair Boland.
Yes.
Representatives Maddock.
Yes.
Green. Jenkins Arno. Kelly. Markkinen. Mueller. Slaw. Van Workum. Beeson. Horton.
Yes.
Roth. Yes. Cavett. Yes. DeSena. Kuhn. Steele. Yes. Robinson. Farhat.
Yes.
O'Neill. Rogers. Steckloff. Glanville. Edwards. Martis. McKinney.
Yes.
Morgan.
Yes.
Price. Snyder. Long John.
Yes.
Madam Chair, you have 26 yeas, 0 nays, 1 pass. House Bill 4328 is reported with recommendation.
Thank you. Thank you for that. And now we will welcome up Amy Epke and Megan Groen from the Michigan Department of Health and Human Services, and we will continue with our conversation from this morning. Thank you very much for your patience and tolerance of us delaying this. And when you get settled, if you could just introduce who else is with you, that would be great.
Good afternoon, Chair Boland and members of the committee. I'm Amy Epke, Senior Deputy Director of Financial Operations with the Michigan Department of Health and Human Services. And as mentioned, I'm joined by Megan Groen, who is our Senior Deputy Director over Health Services and also over the Medicaid program. In addition, we do have representatives from Milliman with us this afternoon. So we do have Jeremy and Chris, and in a minute I'll have them go ahead and introduce themselves as well, as they'll be walking through the majority of the slides in terms of how the rate structure is set. So I first want to just thank you, Chair, and members of the committee for the opportunity. I appreciated the conversation this morning. I do think we have a common goal. We together want to make sure that we're providing Michigan residents with needed services as cost effectively as possible. And so appreciate the opportunity to have the conversation today and talk a little bit about process, make sure we can answer any questions as we move forward as well. And again, I will turn it over to Milliman in a minute just to talk through some of the specific considerations. But before doing that, I just want to provide a few comments on the process. So MDHHS is committed to ensuring access to care for Michigan's Medicaid enrollees. A key component of that commitment is the establishment of the appropriate managed care rates, which are essential to maintaining a sustained healthcare system that supports both patient access and provider viability. The health plan appropriation that we mentioned this morning is one of approximately 30 consensus health services appropriations as well. And of those 30 health services consensus appropriations, those support both physical and behavioral health services. And the health plan services appropriation also mentioned this morning pays for managed care services, as we talked about this morning. And then as a managed care state, MDHHS does adhere to the federal rules and state statutes as well. And again, as we mentioned this morning, federal regulations require a capitation rate be established and paid to managed care organizations for services delivered to providers. The supplemental that was referenced this morning does include that $55 million adjustment. And in order to kind of understand the importance of that adjustment, I do think it is important just to briefly touch on the consensus process, what I think many of you are familiar with. Within the state's consensus process, Michigan's Management and Budget Act does require that Medicaid expenditures be forecasted and considered as part of that May revenue estimating conference that is coming up. Milliman, who we do have again on contract, and they were selected through a competitive bid process, does monitor costs on a monthly basis. They evaluate usage, they evaluate acuity, they evaluate other changes that are occurring in the state. The information that Milliman provides is then used for MDHHS to coordinate closely with the State Budget Office, House Fiscal Agency, and Senate Fiscal Agency to provide the legislature with recommendations on what those appropriation levels should be set at. And those recommendations occur both at the midpoint of the year and also at the end of the year. The supplemental request 2024-8 includes appropriation adjustments needed to close out fiscal year 2024. And then before turning it over to Milliman, I just want to really thank the committee again for this opportunity to be here today. We hope to answer any questions and clarify any issues as we move forward. And really looking forward to working with you and looking forward to support of the supplemental as we go forward. So with that, I'm going to go ahead and turn it over to the Milliman team.
All right. Thank you, Amy. Hello, my name is Jeremy Cunningham. I'm a principal and consulting actuary with Milliman, and I've been supporting MDHHS since 2011 and currently serve as the certifying actuary for the behavioral health managed care program. As a housekeeping note, our presentation today is intended to facilitate live discussion and should not be relied upon as a standalone document. And for our presentation today, we will focus on 4 topics: a high-level overview of Medicaid actuarial rate setting roles and responsibilities, a walkthrough of the primary steps that are used in developing Medicaid managed care capitation rates, a discussion of our general timeline for developing annual capitation rates and rate amendments, including how we incorporate feedback from managed care entities, and finally, we will highlight some of the key items that we are monitoring in Michigan's Medicaid program during the current fiscal year. I will now discuss roles and responsibilities as it relates to the Medicaid actuarial rate setting that apply in Michigan and other states when developing Medicaid capitation rates. Most states contract with an independent actuary to certify Medicaid managed care capitation rates. Federal regulations dictate how capitation rates are to be developed for Medicaid managed care programs. Federal regulations and actuarial standards of practice require Medicaid capitation rates to be actuarially sound. Actuarially sound capitation rates must be adequate to cover reasonable and appropriate costs. For example, capitation rates cannot reflect services or populations that are not covered under the contract between MDHHS and the contracted managed care entities. And capitation rates reflect the estimated benefit and non-benefit costs that will be incurred by a managed care entity based on the terms of that contract. In addition, capitation rates must be certified by a qualifying actuary who develops the capitation rates in accordance with generally accepted actuarial principles. States are required to submit an actuarial rate certification to CMS for federal review and approval, and that rate certification must be consistent with the required information in federal regulations and the annual CMS rate setting guide that's published each year. CMS and its Office of the Actuary review all assumptions and methodologies in the rate certification to ensure alignment with federal requirements. This slide summarizes the responsibilities in the rate setting process among the Medicaid agency, the independent actuary, and CMS. The state Medicaid agency is responsible for all policy goals and coverage design for the Medicaid program in their state, and MDHHS in doing that considers established laws in Michigan and at the federal level. The agency determines when the rating period begins, what rate cells to use to pay the capitation rates, and other structural design assumptions for the capitation rates. The state Medicaid agency works with the qualified actuary to perform the rate setting. The state Medicaid agency assesses the appropriateness of mid-year rate adjustments, referred to as rate amendments, based on information shared by the actuary. The actuary develops actuarially sound capitation rates, prepares the required rate certification consistent with federal requirements, certifies those rates as actuarially sound, and provides all necessary materials for the state to review the certification and provide the final approval for the capitation rates. Finally, CMS is responsible for reviewing and ultimately approving or requiring an adjustment to state-submitted rates or amendments. CMS verifies compliance with federal regulations and ensures states are operating their managed care programs in a consistent manner. As shown on the previous slide, the CMS Office of the Actuary reviews all assumptions and methodologies in the rate certification to ensure alignment with federal requirements. We're now going to move into a high-level discussion of the capitation rate development methodology. First, we wanted to provide an overview of Michigan's managed care programs. As illustrated on this slide, MDHHS has created 5 distinct managed care programs that have different covered populations and services outlined in the program description column and have varying contracted managed care entities. While these programs all have different rate-setting parameters and considerations, the fundamental steps in rate development process are consistently applied across programs, resulting in the certification of actuarially sound rates for each respective program. On this next slide, we will highlight the key steps in developing the benefit expense or the service cost component of the capitation rates. As we discuss capitation rate development, it is critical to note that these rates represent the amount a state pays to a managed care entity to cover healthcare services provided to Medicaid enrollees. Within an individual program, the capitation rates differ by rate cell, which represents the different stratifications established by the state for different covered population characteristics. A certifying actuary estimates each component in the development of the capitation rate, and the following provides an overview of that process. First, we start with the base data period. This is typically managed care encounter data that's submitted to MDHHS by the managed care entities. Encounter data provides utilization and cost information at an individual member level for the historical services covered by the program. In other words, the encounter data is a record of all covered services, healthcare services provided to the population under the program for the period and the cost of these services. Within each managed care program, we summarize the historical utilization and costs by rate cell and service category, which represent the populations and the services covered. The base data reflects a 12-month period from the most recently completed prior year. For example, for the fiscal year 25 capitation rates, data from state fiscal year 2023 was used, which would allow enough time for most of these services to be reimbursed by the managed care entities before we use it for the state fiscal year 25 rate development. Second, base data is adjusted to fully represent the historical experience period. For example, a completion factor may be applied for services that are estimated to have been incurred but have not yet been paid by the managed care entities. In the next step, adjusted base data is modified to reflect policy and program adjustments that have occurred or are planned by MDHHS or are established in state law. These changes commonly include modifications to covered benefits or state fee schedules. And then finally, the trend assumptions are developed by population and service category to account for estimated changes in utilization and unit cost that are anticipated to occur between the base data period, which was state fiscal year 2023 in this case, and state fiscal year 2025, the rate setting period. The application of trend rates to the adjusted period utilization cost results in an estimated benefit expense for the future rating period. After developing the benefit expense assumptions for the capitation rates, an allowance is developed for non-benefit expenses expected to be incurred by the managed care entities under the contract with MDHHS. Non-benefit expenses include administrative costs, taxes such as the insurance provider assessment or IPA, and a risk margin allowance for the managed care entities. Statewide capitation rates, including both the benefit and non-benefit expenses, are then adjusted at a regional level to account for geographic factors contributing to healthcare cost variation for certain programs in Michigan. Risk adjustment is performed for certain populations and programs to distribute revenue to the managed care entities based on the clinical risk characteristics of the population that they are serving. This is performed on a budget-neutral basis following development of the statewide capitation rates at the rate cell level. That includes my portion of the presentation. I'll turn it over to my colleague, Chris Pettit. Thank you for your time this afternoon.
Great. Thank you. Thank you, Jeremy. Thank you, Madam Chair and members of the committee for your time this afternoon. So I know Jeremy went through a lot of technical information on capitation rates, so I'm going to provide a brief overview just of the rate setting activities that were conducted in developing state fiscal year 2025 capitation rates, both prior to this beginning of the fiscal year, which is October 1st, and then those activities that are currently being performed during the fiscal year. So just as I walk through this information on the next slide, just illustrating that this is sort of our general timeline that we utilize in collaboration with MDHHS and the managed care entities and setting those actually sound capitation rates for each of the different managed care programs. So just noting the timeline highlights milestones from our typical process. It denotes how stakeholders such as MDHHS and the managed care entities are involved throughout. The process for the next fiscal year typically begins in April with a rate kickoff meeting. These meetings are conducted in collaboration, once again, with GHHS and the managed care entities for the upcoming fiscal year. So as an example, as we have illustrated on this slide, in April of 2024, we conducted a rate kickoff meeting for the state fiscal year 2025 capitation rates, which started in October 1st of 2024.
Excuse me, could you please draw closer to the mic so we can hear you better?
Yep. Sorry about that.
No, it's kind of in an awkward spot.
No, you're good.
Thank
Hopefully
you.
that's a little bit better. Okay. Apologies for that earlier. So just in that rate meeting, the rate kickoff meeting, we do provide a general methodology for the rate development, discuss anticipated data sources that are going to be used, and talk about considerations for the upcoming rating period. In that meeting, we do not present any initial rates or anything of an actual projection at that time. It's really utilized more as a discussion, both with MDHHS and the managed care entities for the upcoming fiscal year and things that we'll be talking about. During that time, managed care entities have the opportunity to ask questions and provide feedback for MDHHS and actual consideration as we move forward into the next fiscal year. So in June, the next data point or the next event on the timeline here, a draft rate meeting is held with MDHHS and once again the managed care entities. So in that meeting, the purpose is to present those initial draft rate projections based on the summarized data and application of previously noticed adjustments that Jeremy had walked through. It's at this time that we provide a copy of the rate certification, serving as documentation of those initial rate projections for review, including all the assumptions and other things that went into the development of those rate projections for the next year. I will acknowledge, prior to sharing that information with the managed care entities, we do meet with MDHHS to go over the main drivers of change from the prior fiscal year and just point out some of the observations that we have from the summarized data. We then present those draft rates to the managed care entities, who have an opportunity to ask questions during the presentation, as well as in writing following the meeting, and a period of time for their review. Many of these managed care entities employ their own actuaries or hire actuarial consultants to advise them on those draft rates. And then we provide written responses to all questions received after the draft rate presentation, to incorporate certainly into the final rate projections for the upcoming fiscal year. So it is following that draft rate meeting that we incorporate any of the applicable MDHHS and managed care entity adjustments into the development of the final rates that will be offered by the state. As Jeremy discussed earlier, MDHHS then submits that rate certification to CMS for formal review by their Office of the Actuary. CMS conducts their separate internal review of the certified capitation rates, provides questions to MDHS and the certifying actuary for clarification prior to formal approval of the state's rates. So that kind of summarizes the point of submission of those capitation rates or those rate projections prior to the fiscal year. After the fiscal year begins, moving into sort of the green portion of the timeline on the slide, we continue to monitor emerging data closely with DHHS, assessing how utilization and cost compare to those rate-setting assumptions by population and service type. We meet routinely with GHHS to discuss emerging experience, as well as forthcoming policy or program changes that are anticipated to occur before the end of that rating period. And during the course of our review, we collaborate with MDHHS to assess the need for any potential rate amendments. So really just to highlight what we're doing when we're setting those initial rate projections, we're utilizing a snapshot in time of data, utilizing the data that we have at that point in time to project a future period, and then as that period emerges, certainly getting more data, more information to better inform our projections and potential amendments as we move forward. So with that, I'm going to kind of discuss that rate amendment process, what that looks like, and just kind of highlight how we conduct that with MDHHS and the managed care entities. So as I previously noted on the timeline slide, we're routinely monitoring the emerging claims and encounter data as it's made available. Utilizing this information along with supplemental sources of data, we make comparisons to the previously established capitation rates and then prepare updated financial projections for the remainder of the fiscal year. These projections assess cost drivers and reflect data that was not available at the time of the initial capitation rate.
Sir, can you speak closer to the mic, please? Sorry, Chair. I just gotta be able to hear you.
Yep. We provide this information to DHHS for their review and internal leadership discussion. Following this review, DHHS provides guidance on the proposed rate actions that are included in a rate certification amendment, and these amended capitation rates are shared with both the managed care entities and CMS. And it's important to note that there are specific conditions for which we are actually required to amend capitation rates. I will note, in working with multiple state Medicaid agencies over the last 15 years, it's expected that a mid-year amendment will occur for policy and program changes that are projected to have material impacts on managed care entity costs. I will also note it's not uncommon for states to also include adjustments to rates when emerging data is differing materially from those that are used in the rate setting process. So really to summarize, while we're responsible for developing the actual certification and the actually sound capitation rates, we ensure that the process for developing these rates is collaborative with MDHHS and considering all feedback from the managed care entities. So I know there was a request to consider things as we move in, as we're certainly in fiscal year 25. So just noting here some highlights as we're working with MDHHS, we are monitoring those impacts for a number of policy and program changes, as well as increased utilization during state fiscal year 2025. Examples of some of these items are listed on this slide, which you will note do include legislatively approved changes. An additional consideration for 2025, as well as in recent historical years, is the continued uncertainty regarding the public health emergency and its impact on enrollment and program costs. The PHE had profound changes to healthcare utilization and costs early in the pandemic, and the PHE unwinding has also been associated with significant uncertainty as it relates to both the healthcare costs of the Medicaid population that is remaining enrolled in the program. I think we heard a couple times this morning, sort of unprecedented, unique anomaly regarding the PHE. Certainly the enrollment changes and healthcare utilization swings that we've seen over the past few years is certainly unique and something that we have not observed previous to the PHE. So however, all else being equal, we believe there will be greater cost stability in the Medicaid program as the COVID-19 pandemic moves further into the past. So that concludes our presentation, and we thank the committee for its time this afternoon.
Thank you very much for that detailed technical overview. I appreciate that very much, and for the department to be here again. Again, I mean, the purpose is this to kind of garner an understanding what the process is, how we determine the rates, and how we move through the process. So very much appreciate that. Again, we are working all, we're looking back at 2024, looking at 25, and then looking ahead to 26. So very much appreciate that and how this will help us come to a conclusion on 24, move forward in 25, and do properly plan for 26. So you mentioned, and I've heard this quite a bit about the utilization rate, it's up and the people are sicker, but what kind of demographics? And there's also something about regions. So how are the regions determined? And I don't know who this question goes to. And also, do you take, are you identifying and then using the actuarial against, are they X years old, on drugs, things like that, healthy, unhealthy, the individual characteristics of the Medicaid recipient.
Yeah, your first question was related to regions, and so the state determines the regions by which, the state is, managed care entities are organized surrounding specific regions. And that varies, those regions vary depending on which program we're talking about. In terms of capitation rate cells and how we monitor, the primary populations that are covered include the TANF population, which are low-income family populations, the disabled, aged, and blind population, which incur a lot of costs in the behavioral health program, in particular as it relates to home and community-based services, and then the Healthy Michigan Plan program. And so within each of those populations, those three primary populations covered by the state, we stratify those populations by age group and gender to review historical experience.
Okay, and so only by age group and gender?
Yes, and that, again, as I stated at the top, those rate cells have been established long-standing by the department, and so we are working and certainly utilize and leverage those rate cells that have been historically established. Yes.
Okay. All right. Thank you for that. So We hear a lot, having been on DHHS, and so it's just age and gender, but how do we measure if people are improving or getting better health from some of these programs too? Like, we keep getting more recipients in the utilization, but what kind of service or benefit are we providing any benefits to help people maybe get healthier and measuring them, keep track of them?
Sure. So, as the Medicaid director, one of our primary objectives is to really look at Medicaid in a way. Over the last couple of years, we've said, how can this program really make individuals healthier, right? And how can we, when we look at utilizations and costs and things like this, how can we really look at a preventative way so that, if you take something like, diabetes, stroke, heart disease, things that are very expensive, right, that we cover in the Medicaid program. You're looking at, a population that we really want to look. We have worked closely with our partners, the health plans, to look at, are there opportunities for us to really develop some of these drivers so that, people can be, that we can really be increasing their health, making sure that people have access to healthy food, especially pregnant women, children, that type of thing. Like, how can we really look in making sure that we're doing that? We have a variety of quality metrics that we encourage our health plans to partner with us and withhold some of those dollars, right? And then if you are doing better on your quality metrics, you get an increased bonus and incentive for that. And it's something that it's tough when you're looking at, we've got 2.6 million people on the Medicaid program, right? And so sometimes you have to look at some specific populations, right? Like, what can we do here to make these individuals healthier? What opportunities can we have to make sure that we have programming that's going to help them, that they have access to a doctor, that they have access to preventative care? Dental is a big one that we've worked with individuals in this room on. We're seeing a lot of people ending up in the emergency department to get a tooth pulled. Well, gosh, that's not good for the beneficiary. It's not good for the state. It's not good for cost either. And so how can we get on the front end of that? And I just really thank everyone in this room and kind of those who came before you to work with us on those programs. If there's other things that the committee has and they kind of want to drill down on that, we would be very willing to kind of look at some of those initiatives as we do with our health plans and different things. But there's a lot of great things we can do with the program if we really want to take that look.
And thank you very much for the timeline. Certainly, when you look at the timeline, it doesn't necessarily coincide with our budget process in season, if you will, right? And my understanding is generally one actuarial is done, but in the last year, 2 were done.
In terms of the rate amendments, yes, we do look at, there's different opportunities through the year where we can look at amendment. We did do a mid-year rate adjustment in 2024. And then as additional experience and additional data came in that showed us that costs were in fact trending up. And of course, we work with Milliman on that. We don't just hear from people that, costs are going up. We really look at that data. There was a decision made to do another rate adjustment coming out of the public health emergency. We really didn't know, right? And we had an idea. It makes sense, right? Some of the people who are sicker will stay on and some of the people who aren't as sick will fall off. We'd never experienced anything like that anywhere in this country, so we didn't exactly know. And we waited for some of that data to come in order to make that decision because we knew it would happen, but we didn't know how much.
Okay, and then timing, and I'll allow some others to ask questions. And the timing of, and the requests, so some of this came to light and the department became aware of it. And there was some money that kind of floated the increases for a time period. But it's just kind of being more brought to light. Why wasn't something done? Why wasn't it initiated with a, say, budget office or in that part of the process earlier on? It'd be a smaller check, if you will, than it is standing today.
Yeah, that's a great question, and there is a lot of coordination and communication that did occur in the fall and kind of that time frame between October and December. One of the big factors is, as you look at the lines, we're looking at it holistically across the department because you will see even in the supplemental request, some are below the appropriation and some are above. So, and I think as you're aware, the supplemental requests are kind of sent over in batches. to help see the big picture as well, too. Because certainly, there could have been a supplemental request for this one line, but the hope was that, similar to other years, that we may have been able to do a transfer, which is one of the opportunities that we've utilized in the past, too. So you come under in some appropriations, over in others, and then you utilize the transfer opportunity. Unfortunately, that was not the case in this. Once we got through kind of the year-end process and realized when we had all the information that was available from October through December, that we would not be able to do the transfer and instead would have to go the supplemental route.
As I recall, though, last fall, maybe November, December-ish, we did have a request, I think, for a transfer of some sort for some of this.
I'll have to go back and double check, and there may have been a transfer request. I think the piece that we were probably still waiting on is to know if we had other appropriations where we could transfer it from and to, because we didn't necessarily have all of the final numbers and all the appropriations as well.
Okay, thank you. Representative Farhat.
Thank you, Chair. For the folks from Milliman, how long have you guys been the state's actuarial for this stuff?
Sure. I'll hopefully can sound clear. So we have been the actuary, as I indicated earlier, I've been working with the department since 2008. Predecessors with Milliman, I think we've been working with the department since like 1997.
1997?
Yes.
Okay. How often does it go out for bid with the work services you do?
I will defer that question to the department.
Sure.
Currently, the contract that we have with Milliman is a 3-year contract, so it's 2023 to 2026. So in February 2026, we do have the option to extend. There's 2 one-year extensions, so we could extend to 2027 if we evaluate the services are sufficient, and we could evaluate till 2028, and then we would have to go for bid again, and that would be in accordance with the DTMB requirements.
Of course, yeah, and my reason in asking this is, look, some of us sit up here and we see these actuarial results, the numbers, there's numbers that are, 8%, 6%, 7%, whatever it is. How, in the trends that you've seen of other states, or for the folks at Milliman, other states, and for the work you've done since 1997, I mean, has there ever been a year since 1997, this is for folks that don't know, it's before I was born. So since 1997, someone was going to make that joke, I figured I'd make it. Has there ever been a time where you said, actually, no, we got it right, or we don't need to adjust the rate, or, it's a lot less? I mean, these are, 8% it's a big percentage, but has there ever been a time where, the rate has not had to be adjusted that much, or a recommendation was not to be that high? And if I need to clarify, I'll clarify, but.
Yeah, I think, this is, as we mentioned, I would say unlike any time before in terms of just nationally across many states needing to make rate amendments in fiscal year 24 and 25 coming out of the PHE unwind. And so I think in terms of the consistency across the nation in rate amendments, I think this is unprecedented. I do want to clarify in terms of rate amendments that many rate amendments are not related to actual experience coming in higher or lower than projections. For example, in the CHCP program, there is a rate amendment every year, mid-year adjustment to account for fee schedule changes that are tied to Medicare. And so you see rate amendments mid-year. It has nothing to do with projections being higher or lower than what were originally projected. So every rate amendment is not equal in terms of what it actually reflects and whether it reflects actual experience being different than projected.
So then what would, and this real quick, Sheriff, with some latitude, what does a normal increase, and I use the word normal here, let's just, whatever you want to, what is an average, what is a typical, what does it look like not during this era, like you said, we're coming off Medicaid, the redetermination, we're coming off COVID. What does it typically look like? If we went back 10 years or before, what does it look like? I know there's a lot more services we provide now. I get the Medicare, right? We do a Medicare percentage reimbursement. I get that, but typically, what does it look like?
So I would say that's a really complex question because it's not, well, and I'm happy to dive into
I
it further.
appreciate the slide that says, you got to have a rocket science degree to understand this presentation, but you got to help me out a little bit here.
Yeah, no, I appreciate that.
With some,
I will
again, I have a
say-
public health degree. I kind of get it, but I don't, I need a little bit of clarity here. What does it look like? What should it look like?
So I will say when you say typical rate amendment. I don't think you can define what a typical rate amendment is because there are so many policy program changes. And even just looking within the state of Michigan, if you were to look nationally, and I know this joke is used all too often, if you've seen one state Medicaid program, you've seen one state Medicaid program because every state operates it independently. There are obviously some consistencies, but the way those programs are operated on a state-by-state basis varies. So I can say there isn't a typical rate amendment that I can point to. All I can kind of piggybacking off of what Jeremy indicated is most rate amendments are based off of policy and program changes that are implemented and what the projected impact of those are on the.
So my last thing that I would like, because, you know, again, I can read a chart. That's one thing I know I can do. So if you can get me a chart maybe from like 1997, as long as you've been doing this, of your recommendations, I would appreciate that through the chair. Something we can look at and just see, this is what it looks like, here's where it spiked. I would just appreciate that. And even still, you can segregate the data to say, here are added services or whatever that would make the argument the best for us to understand it. But I would just like to see the trend on a broader level of what's going on and why is it so expensive. And I'll just leave it there.
All right, thank you very much, Rep. Farhat. Those are excellent questions. So one, I just want to ask, you made reference to the Medicare rates and doing the adjustment. And so are we obligated to match those Medicare rates? How does that play into our Medicaid?
So we definitely don't match Medicare rates. There's probably some providers that would really appreciate it if we did, but we do have a fee schedule that, you know, we look at a deduction factor in those Medicare rates. They're put out in January, so according to our policy, we do make adjustments according to that timeline. And so that is something that, you know, we do traditionally follow. Again, we do a reduction on a lot of those, so the Medicaid is a little bit lower.
Okay.
But that's how we do it, yes.
Then can you tell me the relevancy of including in doing this in-depth analysis of the Medicare mid-year?
So I guess for clarification here, are you talking with regard to the comment regarding how fee schedules are increased tied to Medicare? Because obviously what we're talking about is we're looking at the Medicaid fee schedules. This the fee schedule that the state puts out, makes updates to those. We're incorporating those adjustments for those policy and program changes. So
Okay, I thought you were evaluating when the Medicare rates come out midterm. Okay.
no, I
Okay.
think consistent with the director's comment, the Medicaid fee schedule that is put out by the state is based off of changes that Medicare does make. However, we're looking specifically at the Medicaid fee schedule
Okay,
updates. And
so it is
incorporating those
based on changes that Medicare makes. Is that what you just said? I'm having a hard time hearing you, maybe.
So it's not based off of, the changes that we're incorporating are based on the Medicaid fee schedule changes.
The changes that we're making. But when you're going through the process, you said some rates come out. What rates? I thought you were referring to Medicare rates.
The Medicaid fee schedule, so the one that the state puts out, is we have a lot of rates that are tied to Medicare. And so when they're looking at it from an actuarial perspective, like we are making those changes from the state side for the Medicaid program, but that is tied to the rates that are in Medicare. Does that make sense?
Yeah, I mean,
I just said
not
it really
using them,
simply, and
why
they
are
could
we
probably
spending
go
the
way
time
into
evaluating them. You know, maybe we can have a conversation later, and why would we use them if we're not really using them? Or why would we make reference to them?
I think many states tie to Medicare because they have a fee schedule for many or the majority of physical health services. And so you're able to say, we're gonna price it 85% of Medicare, and you can control your budget related to that. So it's common for states to tie to Medicare. Michigan is not the only state that ties to Medicare.
But each Medicaid program is the only Medicaid program, right? And so we have some range, if you will. All right, thank you. Representative Maddock.
Thank you, Madam Chair. Does anyone else here feel like we're in Groundhog Day over and over again for the last 7 years? We've got Governor Whitmer's department heads up here every quarter or twice a quarter asking us for more money because someone made a oopsie-poopsie mistake. Well, this mistake is $250 million, right? Right? You can nod your heads, yes. Okay. when we may disagree about that. But it seems like, you know, just earlier today, it just happens over and over and over again. And if I was your boss, I would say, you're fired, you hired him, fire this guy. You're
Point
on
of order, Madam Chair. I don't think they testified that it was a mistake.
No, Farhat's on to something.
Okay, Rep. Maddock, continue. You have the floor. If you have a further question.
Yes. Why don't we take it out of your budget? We're talking about less than 0.5% of your budget to fix this problem. You hired this guy. Take it out of your budget. Start asking the taxpayers for all this money. Thank you.
Thank you. Representative Glanville.
Thank you, Madam Chair, and thank you all for being here today. I've been working on trying to understand the capitation rates, in particular as they relate to the My Choice Waiver Program, for a little bit of time. And so I just have a couple of questions, if I may, about the, and I'm looking, slide number 4, 5? Sorry, this one with the little pictures at the top.
Would you like us to pull it up?
Sure. Might be helpful. No, next. That one. Okay. So you mentioned that from your base data, I believe you have like a 1-year look back. Is that what I heard?
Yet,
Yeah?
when we set capitation rates, typically the base data period, which has to be is required to be a 12-month period. The most recent 12-month period that is complete is 2 years prior to the rating period.
Okay. Okay, so it's actually like a 2-year look back. So your base data, and I'm not saying it's wrong, I'm just saying, I just want to understand, the base data is actually 2 years behind where we are.
Yes.
Okay.
So we receive completed
Right.
base data for state fiscal year 2023 around the February, March timeframe, depending on the program.
Okay. And then you make adjustments to that base data? Is that the rate cells?
Yes, so we summarize the base data, state fiscal year 2023 base data by rate cell and service category. So it's fairly granular. Our rate certification for behavioral health has 87 pages of summaries of the base data by rate cell and service category. There's 50 service categories. And then at that level of detail, we're trending, making adjustments to that data to project from fiscal year 23 up to fiscal year 2025.
How many rate cells are there?
In the behavioral health program, there are 87 rate cells.
Each of those descriptors is a rate cell?
Yes.
And that, in each of them provides like a percentage or something to adjust the rate by?
There is membership for each rate cell and cost associated, utilization and cost associated with each rate cell. And we apply adjustments. For example, a unit cost adjustment in the behavioral health program was 4% was the unit cost that we applied. And so we applied that unit cost consistently across all services, service categories and rate cells to project the 2023 unit cost to fiscal year 2025.
All right, and I'll wrap with this last piece, and maybe I'll get a hold of you offline. I don't want to commandeer the meeting here. But I just am trying to understand, so if year over year, the capitation rates look quite low in that we maybe are not able to provide service to everybody who qualifies, I'm wondering if your base data is off somehow, or if that 2 years back, and I understand why you have to do a look back to a complete year. I mean, that makes sense, but it's still 2 years behind. And so if our base is off, you know, I don't know how you adjusted for 2020 or 2021, but that error is going to continue through, right? So I'm wondering, like, if it's the base, I don't know how the base data is necessarily figured out or what those adjustments look like, but I'm wondering if that's where there might be some place to look, because, you know, as we see these capitation rates not being adequate year over year, it seems like they need to get a little bump up from the bottom and then reset or something. I mean, maybe I'm being too simplistic, but.
Yeah, the state has an encounter quality initiative process for each program that is reported by each managed care entity what the costs of services are for the covered population. The base data is extremely important, and the state has invested in understanding that base data. There's, in addition to encounter data, there's plan reported information for that historical data period as well, and we're comparing the encounter data to that plan reported data and making adjustments where needed. So that's something we're happy to talk with you more, following this meeting. But I do want to just point out that there is a big initiative to look at that base data and make sure that it is complete and accurate, not only by the state and Milliman, but also by the managed care entities and the data that they submit to the state.
Are you putting out a report on that? You said there was an initiative to look at that?
It is an ongoing initiative. It's a project between the state, Milliman, and the managed care entities within each program to collect data from the plans and the encounter data and make sure they're reconciling. And that comprises the base data that is used for the rate setting.
So if they're not reconciling, what?
I'm suggesting that there is a lot of effort been put in and they are reconciling.
Thank you. I think that, you understand the representative's point in trying to understand the reconciling, but also it seems based on the references made throughout today on this is that, going back to a base, we do have one of you or in several of the discussions about these anomalies and how unusual. And if we're going back to, the peak COVID, that's really not a baseline we should be using either. So as we move forward, I think we all need to be very conscious of that and to not be fooled by that. Representative Van Workum.
Thank you, Chair. I got, a question for Milliman and the department here. First one is you had referenced the code, the federal code that you base your assumptions or your actuarial study on. Having done some different actuarial stuff, is what they put in there, is that enough data for you to make a sound decision, or does some tweaking need to be done on the federal side that would help create these adjustments? Are based on what they require you to do and how you have to do your actuarial process, is there something on the federal side that would make this better, that we could create more accuracy?
So I will say, from the federal standpoint, since I've been working on Medicaid capitation rate development, there's been a lot of increased, I'll call it, oversight scrutiny from CMS. A lot of, I think, my colleague Jeremy alluded to the, 66-page rate-setting guidance that CMS produces on an annual basis, updates that, looks at federal rules. So I will say, from that standpoint, a lot of additional information and requirements and documentation has been required and requested by CMS. That certainly allowed for additional transparency, additional documentation for, once again, not just ourselves to put together, but for managed care entities and the department to review. So I would say, from the federal side, I know they're continuously working and putting out surveys to understand, how things are working and ensuring that they're collecting the appropriate information. I know they've got a lot of work on their side to even review encounter data and things of that nature. But I think to the question about enhancing the accuracy, I think once again, it's something that we're working with the department and the managed care entities on a collaborative basis routinely to monitor that emerging experience and incorporate as much up-to-date data as possible. And I know, keep alluding to it, I think over the past couple of years, and Madam Chair alluded to, 2020 and 2021 during the sort of peak COVID time period, not a data period that we want to utilize. So I think even going in and coming out of that, recognizing there's some nuances there that we have to account for and trying to sort of weed that information out when developing future rates. So I think, there was a question or a request about just stability moving forward. Certainly, there's been a lot of fluctuation over the past couple of years. And as I alluded to at the end of my presentation, really looking to, I think the population is stabilizing more now that we've come out of that unwinding and seeing that more stabilized enrollment in the Medicaid program. It's just not just in Michigan, but hopefully on a national basis as well.
And then for the department, we talked a lot today about the process and how we got here, but we aren't really talking about the why of what are the drivers of these costs. And I guess my question, I think there's several different ones we can look at, but the one I'm interested in for today is back during COVID, I believe the department made the decision to go off of the formulary and do a preferred drug list. And we were told that this was going to create savings. One, has this created savings, or has it actually increased the cost of the drug benefit? And two, and this may be back to middlemen, from the rebates, which was kind of one of the arguments when the department made that decision, was the rebates. When you guys do your actuary calculations, are you incorporating the rebates that the state receives into your work?
So I'll answer that other question, then defer to DHHS on the single PDL. The rebates that the state receives are not incorporated in the development of the capitation rates. The Medicaid managed care entities, and in particular for the CHCP program, those managed care plans do not receive any of that rebate, so therefore we do not adjust for those rebates that the state receives in the capitation rates.
So just to add a little bit more about those rebates, there's a difference between what the plans are spending and then what the cost is to the state, right? And so where that's something where the plans are spending, the state does see a lot of that cost come back in those rebates. We have rebates that essentially null the cost. We also have large classes of drugs where we see an 85% rebate, those types of things. I don't know all of this off the top of my head in terms of what all the drug classes are, where we get the rebates and things like that, but that is something we are happy to provide to the committee, do a follow-up in writing of kind of where we are with the PDL, what rebates are looking at. There's things that we can kind of, share at a very high level that might help understand just a little touch base of like how that PDL is going, what costs we're seeing, and those rebates are very significant for a lot of high utilization as well as high cost drugs.
So to the original question, have we seen savings from going from the formulary to the preferred drug list?
It depends on exactly what piece you're looking at. We can certainly follow up with some more information. I don't know off the top of my head what those savings have been.
So I just want to follow up on Rep. Van Werken's question, and I do think it is an important one in looking at the cost savings, but this was policy. We've had that reference about policy decisions impact the dollars. And so was this a policy decision that was made by the department and approved by the legislature since they're the appropriators?
So in terms of a policy decision, that was something the preferred drug list and that policy change was in the state budget. And so that went through the appropriations process.
And that includes the change, like the weight loss drugs. We've heard a lot about those and the cost of them.
Sure, I'd be happy to talk to GLP-1s. So in terms of GLP-1s, the decision to cover GLP-1s beyond diabetes, because diabetes is required, every state covers GLP-1s for diabetes. In the state of Michigan, that's about 60% of the GLP-1s are for diabetes. If you look, we have about 2 years of data now, so it's probably a little bit early to see what the cost is. If you look at obesity is a major driver of Medicaid spending. We've got over 40% of adults in our state classified as obese. And we do, for those individuals, we do a prior authorization. There's criteria around an individual having a BMI of 30 or over, as well as it being part of a holistic treatment plan, so that needs to include diet, exercise, that type of thing. The Medicaid program does cover GLP-1s. They're clinically proven. Again, we don't have a lot. We only have a couple years of experience because that's how long they've been available in that. At the time the executive budget recommendation came out, the federal government did have a rule that was proposed to require Medicaid programs to cover GLP-1s for weight loss. Just over a week ago, we were notified that rule was not going to be moving forward. So I do think there's an opportunity to have a conversation around GLP-1s that I think we would welcome too, because is it never? Do we want to look in smaller populations? We do have about 34,000 individuals that are taking GLP-1s for weight loss.
All right, thank you for that. Yes, I do think that is a conversation that we should definitely entertain sooner than later, but in that conversation, I'm probably under Rev Van Worken's committee. I think we also should make sure that we're gathering the demographics and looking for tools of measurement, like are they helping, are they aiding, or is it not at all?
Yeah, and I'm sorry, Madam Chair, I did not mean to interrupt you. We would welcome that conversation.
Excellent. Thank you very much. Okay, Representative Long John.
Thank you, Madam Chair. Thanks for everybody's testimony today, too. My question is intended to help us all learn from this past year's unexpected increases in costs and avoid future surprises. We heard this morning that whether it's policy changes or a pandemic, et cetera, that when there is increasing uncertainty, that it leads to a risk of less accuracy in modeling. You just don't know what you don't know at the outset of modeling something. We also heard this morning that there are national trends of increasing acuity in the Medicaid population, that there are increasing national trends of drug costs, and that these are national trends. But we did make some changes in policy in Michigan related to dental services for preventive services that might be unique to Michigan. I just want to make sure that as we learn the lessons from this past year, as a preventive medicine guy, you know, we often say you pay now or pay later. And as we're looking at programs like the dental preventive services program or things like the diabetes prevention program or things that have been shown over and over again to have a cost savings and return on investment that take 2, 3, 4, 5 years to produce, that we don't misunderstand the lesson. I'm wondering if you could speak to the risk that we have or the likelihood that we have if we insert uncertainty or cut services too early, that we are actually asking taxpayers to pay now and pay later. What is the importance of staying the course on preventive services in the program? Again, whether it's the DPP or addressing social drivers of health, things like that. Is that stuff that you can help us model and avoid making taxpayers pay now and pay later? Are there lessons to be learned?
Yeah, I think that's a great question. I'll start off, and I think others will certainly join in. I think this is exactly the conversation that we need to have, and I really appreciate that. As we've talked about, we know, at the federal level, there are mandated and there are programs that are considered optional, but at the same time, even when they're considered optional, in many cases, there's Michigan statute that requires it, whether it's the Michigan Social Welfare Act or other areas around prescription drugs and things like that. So I do think it is finding that right balance, because as you've talked about, it is about, some of these costs up front will prevent, costs later on down, and what is that right balance? But I'll certainly defer to others to add on to that.
So, just to put it really simplistically, preventative care is a lot cheaper, right, than when you look at what the big drivers are in the Medicaid program in terms of cost. It's actually a small group of individuals that are driving most of that cost. A lot of that is because Medicaid's the payer for long-term care, right? And so that is a very costly service. About 80% of the services covered in Medicaid in Michigan are federally required. They have to be a part of, in order to have a Medicaid program, the federal government mandates that we have them. So that's 80% of those costs right there. When you look at that 20% of optional services, I just want to make sure everyone knows what those optional services are, because 80% of that 20%, so we're getting a lot smaller here, are home and community-based services for individuals with intellectual and developmental disabilities. They are in pharmacy. And so, can we look at reducing costs in those spaces? Sure, but they're not things that I think, if you were to ask somebody, what's an optional service that you guys cover? I mean, as you get farther in there, maybe there's pieces that we can look at. Maybe we can look at, GLP-1s, but what is the actual cost of that when we're getting 85% back in a rebate? And so looking at those numbers, the third biggest driver is hospice. And so, which is an optional service. And so, as we're looking at what those are, some of the preventative pieces that we do, I'm not saying that they don't have cost savings, but I think you're right to take a serious look at they're not super expensive services, and if we're going to see investments now that can make this population healthier, I just want to make sure that we're doing that collectively and having that conversation so that we can all kind of take a look at what that looks like as time goes on.
Thank you for that. And we're going to just have 2 more questions, Representative Green, Representative Steele, and then we have to get back to session, folks. So Representative Green.
Thank you, Madam Chair, and this is probably more for the Millman guys. But as we talk about as we talk about changes in policy that determines what your, where your rates are, and that's where sort of I'm wanting to park is that rate such. What would you say? And when I say that, meaning, you know, we're not going to hold you to this, but just ballpark. What percentage of the changes in policy come from enacted legislation, whether on the federal or state levels, versus what percentage comes from departmental fiats? I'm sorry, lack of a better term.
Yeah, and so just to be honest, I'll have to defer to the department on that because I know we communicate with them on a routine basis of here's the fee schedule changes and other things of that nature. We're not 100% clear on everything that's legislatively approved versus departmental decisions, so I would defer and certainly couldn't provide any information off the top of my head what that percentage was, and certainly I assume the department able to follow up on that.
Yeah, we'll have to get you a specific percentage, but I would say the vast majority is based on legislation enacted, whether that's things that certainly now for 2025 we'll have to take into effect the new minimum wage. That will increase costs as well and things like that. So just examples like that, but we'll certainly go back and get some more, unless Megan, you want to add on at this point.
Well, I don't know a percentage off the top of my head, but I do want to just, you know, it might be helpful through this process to, you know, we do have boilerplate in the budget now. We are required, and we do send the legislature with a minimum of 60 days advance notice, the submission of any state plan amendment, any federal waiver requirements, just, you know, that have a material impact. And so all of those policies are also out for public comment. We do a fiscal piece, and we're happy to work very collaboratively with you, and we want to make sure sometimes, you know, when there is a change in the state law, there's also a corresponding Medicaid policy change that needs to be made, right? And we try to be transparent through that process, and legislative input is always welcome, and we look forward to working with you on those.
So there are many times where the departmental internal rules change, and it's not just legislation.
No, the legislation will require a departmental rule change in terms of a Medicaid policy bulletin will have to be put out in response to something that was in the state budget or legislation. And so anytime there is any change, we do, that there's to the state plan, to the waiver of the federal authority, we do notify the legislature, and we can make sure that those are going to the right place and that you guys are all in the loop, and we're talking about the fiscal impact of those.
I think that brings up an excellent point, Representative Green, and, you know, sometimes we get a lot of reports that are sent and the legislature requires them, and we get so many things, we don't really know. And so as we're going through this process in things that as members of the Appropriations Committee, you will get a lot of reports and boilerplate. If you don't find that they're satisfactory, if there's a better way that we can do them, so we can actually be, while we're transparent and they're delivered, a way to make sure that we're actually reviewing them in substance and provide the input when they're up for input versus after the fact, I think would help us in the long run and long term. So thank you for that. And Rep. Steele, if you can be quick, please.
Okay, quick 3 questions. First question
One
is.
question, please.
Point of order, point of order, point of order.
There was a timeline in which MAHP discussed on them of how they find their numbers and their actual, their numbers in which they have to do their budgeting or earlier. And Millman has a timeline. Are your timelines corresponding each other to where what they need and what you guys say that they need are corresponding with each other, like you two work together?
So in terms of the timeline, I think the information that the association, the Health Plan Association presented this morning was in regards to when certain, like initial rates went into place, when the rate amendment was implemented, and just so the timing of that. So I think our communication, as I indicated during our timeline, we are always in communication with the department and the managed care entities in terms of what we're looking at, what we're considering. So we've always included them in communication and participation in the development of the rates.
Okay, and then the second one is about the Medicaid. 80% of it is federally required, but 20% is optional. What is that dollar figure of that 20% that Michigan provides in addition to, let's say, other states? I think our services might be richer. And when you talk about this weight loss drug, I don't necessarily know if people that actually pay for insurance actually have that benefit, but we're offering that benefit for Medicaid recipients. And so I'm curious, what is that weight loss drug? $20 million a month or $300 million a year that we provide at the state level? And I don't necessarily think that private insurers provide that. So I'm not looking so much about what the future is like. What are we comparing right now to other states? And I think our rates are higher and we pay more money because we offer richer benefits compared to other states.
So a couple of things in there, and I know we're pressed for time, so we might have to follow up with some additional information, but I would be happy to share with you, we put together some information for the Senate Appropriations Committee that really shows how Medicaid, especially Medicaid in Michigan, has really controlled cost better than the commercial market, better than Medicare, better than employer insurance, and so we can really show you how we've contained costs over many years, and the cost of healthcare is going up. It's going up a lot lower in Medicaid. We can certainly follow up on GLP-1s. I hear that one loud and clear and look forward to that conversation. Again, that's something, we are not the only state that covers GLP-1s. There are private insurance companies that absolutely do cover that. Whether or not it's time to look at a policy change is certainly something that we can do. But just, again, we only have experience data from around 2 years right now.
All right, but now is a good time to start, what we want to measure and how, or. if we're gonna continue.
100%.
Right,
We should
right.
have a conversation about what that looks like in the
Excellent.
program.
And along the lines of what ran for Workham. And I want to thank everybody for being here today. Thank you to the committee for your patience and grace. And very, very much appreciate the conversation. Look forward to continuing it so we can do good things for all of Michigan. And with that, I'd like to excuse the absent members. Rep. Farhat excuses the absent members. Hearing none, members are excused. And with that, we are adjourned.